Hi, I'm Michael Battelle, president of the Fatty Liver Alliance, and you can find us on our website at fattyliver.ca. I'm here today with Dr. Manal Abdelmalek. She's a professor of medicine in the Division of Gastroenterology and Hepatology and the director of the NAFLD Clinical Research Program at Duke University. Manal, 2021 has been quite a year. What sticks out for you in the NAFLD NASH landscape?
Well, certainly we were all hopeful to be out of this COVID pandemic in 20 early 2020, but this has dragged on, and I think what has been most striking, at least as it pertains to the COVID pandemic, is the fact of the impact of social isolation, of quarantines, of lack of physical activity and dietary changes having an impact on weight gain through COVID. So while patients were able to kind of get on track, I think many got a bit derailed in their ability to effectively maintain lifestyle modification and remain as physically active as we would have liked through the COVID pandemic. So we'll need to get on track with that.
You called it one of the last times we spoke. You called it the COVID-19 because people gained 19 pounds, right?
Yeah, on average.
Yeah.
Some less, some more, but the trend has been some more propensity towards weight gain through this time.
And I imagine for some patients it was difficult for them to see their specialists for at least a period of time over the last year.
Myself, speaking from my own practice, I was forced to see patients on a virtual platform for many months through the initial onset of the COVID pandemic, and that was challenging, even for me as a provider, to be able to provide care without being able to examine my patients, and it was particularly a hardship for those patients who had advanced liver disease, and we got through it, but it was not our traditional way of practicing medicine. So we've learned that there are certainly certain patients that you could see on a virtual telemedicine platform, and that renders some convenience, especially if it's only for medication refills and a quick check-in. And other patients you really do need to continue some on-site assessment and monitoring.
Yeah, we definitely have to adapt. People use the word pivot a lot, so stay away from that one, but we pivoted. I wanted to know what you thought, if we've made progress in different areas. One of them is, patient education. Do you think that we've moved things ahead over 2020? Let's start with that one for patients.
Despite the whole pandemic, I think we've made some incremental advancements, certainly with work such as yourself, the Fatty Liver Alliance, the Global Liver Institute, our patients spending more time trying to get information about their health and wellness on virtual platforms. We've been able to impact patient education. The acronym of non-alcoholic fatty liver disease, or metabolic liver disease, or obesity-related liver disease is no longer foreign to our patients. And I think we have made an incremental advancement in public awareness. We certainly have a lot more to do on this front, because now it's not, what do I have? The questions are, where do I stand with my disease? How advanced am I? What interventions will or won't work for me? So I'm seeing that we have made a dent in awareness, and now there is more to do, certainly, and a broader reach we need to have. But the signs are showing themselves that this isn't as foreign a disease entity as it was 5 years ago, per se.
Yeah, some of the challenges, of course, are just having people pay attention to liver in itself.
Yeah.
And so,
yeah, and I think that awareness is definitely there, even in the medical community. the element of metabolic liver disease is more astutely on the radar screen of our endocrinologists and our cardiologists and our obesity specialists in primary care. And it's not, the recognition of fatty liver disease that is a challenge as it is, risk stratification and prioritization. So we have more to do. We have more reach to achieve, but I see advancements in education happening. I also think we've made incremental strides in really understanding the limitations and the challenges that drug development has been presented with. We've had some very promising therapies for fatty liver disease, which fell short, and they fell short due to insensitive endpoints or or placebo effects or inadequate power or and that awareness, that understanding of the endpoints that we are using to evaluate the efficacy of therapies will hopefully lend us the insight necessary by which to make alterations in trial design, engage with the FDA and EMA about alternative endpoints, or to look at the holistic approach to evaluation of new therapies in a different way than just one isolated endpoint that is heavily weighted for liver biopsy, change in liver biopsy.
I totally agree with that, by the way, right? It's not always even about the quality of the medications that are being developed. It's the way that it's being looked at for the endpoints. What are we trying to solve for? Is it weight loss or is it a metabolic solution?
Yeah, I think we will certainly gain more knowledge as we move forward, and I think the therapies that are going to hold the most promise are those that can achieve improvements in the metabolic risk factors as well as weight loss, and allow patients to sustain that long term with a good safety profile.
Yeah, I agree. You touched on something too. I wanted to go back to the team approach is definitely something that needs to be focused on in 2022, right? Because it's not just a hepatologist that can handle everything. And so you mentioned endocrinologist, a cardiologist, nutritionists, maybe a behavior specialist, psychologist or something, because you do need that behavioral support too. What do you think about that approach?
Well, there's no doubt that in order for us to manage this condition well, we really need a multidisciplinary team. This is not all about just the liver. The liver is the hepatic manifestation of a metabolic problem. And in order for our patients to be successful in achieving their therapeutic goals, even with lifestyle, we do need nutritionists. We need exercise physiologists. It is so striking to me how often we tell patients to diet and exercise, and that's understood, but we don't give them the right tools by which to do it because it's not one size fits all. So if patients have chronic back pain or degenerative conditions of the knees or their joints, weight-bearing exercise can be very, very challenging for them. But if they're evaluated by exercise physiologists and specialists, we can develop more prescriptive approach to what type of exercise and how to achieve it. Maybe for some it's not weight bearing, for others it's aquatic, or others it's resistance exercise as opposed to aerobic. But we really need to tailor our approaches to lifestyle intervention in a very patient-centric way. Other patients need evaluation of sleep apnea or chronic conditions that is perpetuating their metabolic syndrome, for which they may not even know about, that worsens their insulin resistance, like polycystic ovarian syndrome, obstructive sleep apnea. And I think we need to step back and evaluate patients in such a holistic manner that we can set them up for success. Because if we leave any stones unturned, we make blanket recommendations and our patients don't have the tools by which to know how to get from step A to step B.
It may be that NAFLD and NASH together are going to be one of the most tailored approach requirements for any kind of disease, because it does manifest, there's so many different ways that the patients seem to be impacted by it. And so when we say, you just need to lose 7 to 10% of your body weight and everything will be great, but maybe that won't work for a particular patient, right?
And maybe we should make smaller, milestones for achieving those successes. 7 to 10% weight loss can be pretty daunting depending on how much weight you have to lose. So it will require routine care, routine follow-up. This is a condition in the same way we treat diabetes. We don't say, here, take this insulin or take this medication and I'll see you in a year. It really does require routine management and reassessment of goals, and retailoring of the therapies based on a patient's acceptance, ability to comply, and the efficacy. Not all therapies work for all patients, depending on the root cause or the drivers of disease.
I wanted to also ask you, do you think that we've gotten to the point where we could say to patients that they should talk to their primary care physicians, and to primary care physicians that they should talk to their patients if they are type 2 diabetics, and that maybe they're diagnosed as or defined as being obese, so maybe BMI over 30 or something? Are we at that point where we could at least look at that population?
I certainly think patients should engage with their primary care physicians in a discussion. Not only is having fatty liver disease in the context of being obese a risk factor for diabetes, but having diabetes in and of itself is a risk factor for having more advanced liver disease if you have fatty liver disease. The discussion with a primary care physician certainly starts once the diagnosis is established and once the severity of disease is clarified. But it does not necessarily have to be all about diet and exercise. That is certainly the foundation for all patients. However, there are some patients for which the dialogue can be around therapies to improve weight, therapies to improve their diabetes if they have it, discussion around bariatric surgery if patients or otherwise have many metabolic risk factors, that those risk factors in and of themselves can pose a risk to their health and wellness, increase morbidity and mortality. And there's even further research going on with endoscopic bariatric approaches. Plus, we have a very robust and emerging landscape of investigational studies currently being evaluated for fatty liver disease. But if you don't start the conversation,
Right.
Then what options are best suited for any unique individual would not be a discussion that would ever be had.
Well, wise words to end the year. Thank you. Any other words of wisdom that you want to share with people as they head into the new year?
I think the future of fatty liver disease is very promising. A lot of very exciting data has unfolded with regards to the genomics and genetics, tailored approaches to therapy, finding the right therapeutics in the future that will be most beneficial for any unique individual based on genomic profiling or metabolomic profiling, or even integration of that type of data that gives us a signature, if you will, or a footprint as to what would best suit any one individual, whether it's diet or exercise, or whether it's drug A, B, or C for their fatty liver disease or metabolic conditions. But we're going to cross that bridge, and I think as all the data emerges, both with regards to genomics and genetics, as well as therapeutics, we're going to find ourselves in an era of being far more precise, precision medicine, not only with the treatments, but far more precise, I think, in evaluating and predicting treatment responses than we currently are.
Let's hope so. Thank you again for a wonderful discussion. Happy New Year, and look forward to 2022.
Oh, Happy New Year to you too, Michael. I really appreciate the opportunities with you.
We'll do this again. Thanks.
Okay, certainly.